And I commend each of you for your excellent testimony. Let me just get quick answers here from all three of you. I think what I'm hearing from all three of you is that this is going to require more than simply good management of what we have on the books now. Each of you is recommending changes in the statute that need to come in this coming NDAA. Is that right, Dr. Robb? And yes. Dr. Friedrichs?
Yes, sir.
And Dr. Cannon?
Yes, Mr. Chair.
Okay. Now let's talk about military surgeon readiness for combat care. There was a study out in 2021. It found that the population of military general surgeons meeting necessary readiness standards decreased from an already low 17% in 2015 to about 10% in 2019. We'll let all three of you take a brief chance at answering this. Why is this happening, and what specifically can DoD do to reverse this trend? And we'll just start with Dr. Robb and go down the table.
We'll try to share different perspectives here.
Okay.
I think it comes back to the system to be able to resource the requirements that we need. And so, for example, if you want to look at, Dr. Cannon referred to the 5 to 8, what we call critical military treatment facilities. In order for us to provide higher volume, high acuity care, they need to be resourced. And I think that's the challenge that we all face right now is what's that strategic reserve with our military treatment facilities? And then how you augment that with the VA and the Department of Defense partnerships, and then how do you augment that with the military civilian?
Is that what he called this, the centers of excellence?
So I would call them, that's one way to call them, but what coming from the airlifter world, in fact, General Friedrichs and I will both say, follow the casualty flow. And the casualty flow comes in from Indo-PACOM to primarily will become into 2 or 3 military treatment facilities. From Southcom, they will be coming into the National Capital Region. And then from Europe, CENTCOM, and AFRICOM, they will be coming into primarily National Capital Region and with a pop-off at Portsmouth.
Okay, Dr. Friedrichs, is this 10% number a concern, and why do we have a 10% of eligibility, 10% of military surgeon readiness?
Mr. Chairman, it absolutely is a concern. When I did my training in the military, I trained at the old Wolford Hall that was a level 1 trauma center. I took care of trauma patients because it was a 36 on, 12 off schedule every other night. Or I took care of vascular surgery patients, or I took care of cardiothoracic patients. We've de-scoped our facilities to the point that they take care of low acuity community hospital patients, not trauma patients. So I would reiterate the point that you've heard all three of us make. We need our key hospitals to be level 1 trauma centers in partnership with the American College of Surgeons and the communities in which they're located. But to do that, we must address the elephant in the room, and that's resourcing. The medical inflation rate on average since 1938 is 5.1% per year, and the military has seen a net 12% reduction in funding. There is no way to fix these problems if the military health system is viewed as a bill payer and not something worth investing in. The second point that I would make is we've got to reiterate the intent that you and the ranking member mentioned. I spent 4 years as the Joint Staff Surgeon. Almost every meeting in which I participated in that role focused on roles and responsibilities and patches, not on patients. Please, again, I implore you, kill this narrative that somehow there's a belief that we can unwind things and go back to the good old days. We need to go forward towards a more integrated system that focuses on patient care and, as you said, on readiness, not continuing to focus on bureaucratic buffoonery.
Dr. Cannon.
Mr. Chairman, it's shocking, astonishing, and awful, and it has to be reversed. That 10% number results from inadequate, actually grossly inadequate patient numbers, volume. They're not doing the cases, they're not doing the procedures, they're not doing what they were trained to do. And that's because they don't have the patients in the facilities. They're, in many cases, not designated or verified trauma centers. So they're scrounging around trying to get cases and it's been, frankly, an uphill climb. So we've got to provide them the patience, the cases, the experience to write that 10% number.
Thank you very much, gentlemen.